Probably 7:30 would be a good target.
I just want to let my ride know.
Yeah.
So
Okay.
we can start heading here and then I don't have to hang around.
Sure, yeah. Can keep me here late.
Yeah, because I felt terrible about that.
Well, teachers don't have lives, so. That's what I used to think. I used to think my teachers were a bunch of losers and had nothing better to do. And then I became a teacher and realized how exciting it is.
Realize you actually are losers. Now you're like, dang.
Thank you, Courtney. I wasn't going to quite put it that way. I was going to say how I realized they're not losers.
I will miss Tuesday when I met, or last Thursday when I met, and really let me for voice recording. I will have to say that I'm listening to it, and the funniest thing I busted up laughing at it when you had your wisdom. They were like, we can laugh at was when you were talking about the RNA viruses. And you're like, just give me,
Give me hepatitis.
I just want you to give
I had a
me.
great day that day.
I laughed so hard. They were all like,
HIV and rabies.
Well, we'll have a little fun next class then. Bring a little prop to the next class. We'll have fun with it. That's right, I did that at Micro, didn't I?
No, it was Amy.
Was it really? Huh, I don't usually bring those toys to A&P. They're very adult. What is he talking about? Everybody's paying attention now. He just said adult toys. And yes, the recorders are on. Let's bowl at 6. I know a lot of you weren't here. Don't worry about it. Everything we did the other night we're going to repeat. So I guess the benefit of being here is that some of you already have a coat of paint on what I will probably finish with tonight, I think. Let's peek at our schedule briefly. We've probably got to do something about that exam 3, which is scheduled for Tuesday. I think we got to, I'm sorry. Exam 2, which is scheduled for next Thursday. Sorry. Yeah, what have you all been reading? Which is for next Thursday. I think we are going to do the same thing with that and bump it to the other side of that weekend. I think he's going to be pushing it to finish this handout by then. I think we can, but it might be pushing it, and that gives us a little time next Thursday for review if we need to, but I will kick into Unit 3 that night, and so kind of be able to get your brains on Unit 3 mode for a lecture and then come back and do that exam. On Tuesday, I can tell you right now what I'm going to do is flip-flop the rooms. So I think it was M through Z was in the different room, and A through L was in this room. So we're going to flip-flop that. M through Z will be in here. A through L, I don't know. I think that my room is available now, but I'll double check. If not, we'll do it downstairs, which is 120, right below this room. I'll remind you all of that on Tuesday.
So exam 2 is on March 5th?
It is. Is that the next Tuesday? Yes, it is. March 5th. Wow, March is right around the corner. Oh.
January seemed to last forever. February was gone.
Well, February is a shorter month.
3 days.
Okay. That was your Captain Obvious comment of the evening. February is a shorter month. Okay, let's do it. Let's get Unit 2 done, or close to it. I believe we stopped after talking about macrophages. And again, I know some of you were here Tuesday. We covered my little cell story, and I'm going to do that tonight. Man, I wish they'd move these out of the way for me, but I guess they figure I need my exercise. Okay, we'll do that tonight. Sorry, I wasn't really doing that. Oh, it hurt my foot. Okay, so macrophages. What did I do with that pen? Big eaters. One thing to really know about macrophages, and you're going to see more of this in a diagram They are the ones, and I think I closed with this last Thursday, they are the ones who bridge the non-specific immune system with the specific immune system. Another way of saying that is macrophages bridge the second line of immunity with the third line of immunity. Okay, they're the only ones with authority to kind of hang with lymphocytes, sort of. Protein cascades. Protein cascades. There are two of them. We are not going to worry about the coagulation cascade right this moment. That's about blood clotting. We will talk about that either in this unit or the fourth unit, I can't remember. What I want to focus on tonight is the complement cascade, the most important group of proteins you've never heard of. If your A&P teachers mentioned this to you, good for them. I don't. I might mention it actually to my class, but I don't ask them to remember it or know it. But these are very, very important proteins. We usually abbreviate them C' for shorthand. I might have that in the handout, which is why I'm telling you that. They're all made in the liver. I think there's about 20 of them. I don't even know the exact number of complement proteins there are. They're all made in the liver. They help the inflammation, which is the second line of defense. That's what they are classified as, inflammatory proteins. I actually, this is correct. What I have in your handout is not. I put C asterisk. I just noticed that.
Is that a line like
That's
up?
that's an what's that called? An apostrophe?
Oh,
What's the thing that the
okay.
upper right? Yeah, apostrophe S. Yeah, apostrophe. This is why I don't teach English, obviously. Okay. Sorry about that typo. You can change it. It won't be a big deal. You're not going to need to know the shorthand for the exam. I'll say complement proteins. I'll write it out. And if you want to follow what I'm saying here, it's underneath that inflammation section. There's a little section on the complement proteins. I'll get to inflammation in a second. Definitely know the four things that complement proteins do. They opsonize. That sounds very positive because it sounds like optimize, but it's not. It's opsonize. I'll explain in a minute. They act as anaphylatoxins. They act as chemotactic factors. And in some cases, they kill. Period. Opsonize, what that means is promote phagocytosis. Promote phagocytosis. Complement proteins make things look good to eat by white cells, like neutrophils and other phagocytes. Okay? They promote phagocytosis. Act as anaphylatoxins. They turn on eosinophils. Anaphylatoxins actually can be dangerous. Have you all heard of anaphylaxis?
Yeah.
It's like an allergic reaction that's all over your body. It's not just, ooh, I've got an allergic rash on my hand. It's allergic all over the body, and it is a medical emergency. Anaphylaxis is what happens to someone who has a true peanut allergy and they eat a jar of peanut butter, something like that. They would be in big time trouble if there wasn't a hospital right next door. And even then, we're not sure they're going to make it. Okay? So complement protein, sometimes you're supposed to have allergic reactions to things. It helps kill it, but it can get out of control. Chemotactic factors, chemical attractors. Chemotaxis means movement toward or away from a chemical stimulus. And complement proteins, what they do is they're kind of chemicals that attract white cells to the site of trouble.
Chemical factors?
Chemotactic factors. And finally, they kill. I don't really need to explain what that means. It's exactly what it says. They kill. You should know, you do not need to know the three pathways of the complement system. That's the next row on your handout. but you should definitely know the opsonizer. I tried to say that like Arnold Schwarzenegger, it didn't come out quite right. I'm the opsonizer, or like Terminator. Sorry, I had a ton of sugar at dinner, so I'm a little jumpy. Anyway, where were we? C3b. That is actually the name of the protein, C3b. These complement proteins are named by a big C and a number, sometimes a little letter. Know that C3b is the opsonizer, and know that the MAC complex, also known as membrane attack complex, is C5 through 9. C5 through 9. Well, the B you can, but I'm not going to give you 5A through 9. Okay, so if I give you, you're looking for 5 through 9, your other choices will be different numbers. So
Did you say B or B?
B is in boy. Everybody get those on the complement. There's potential for 3 or 4 questions on the complement system, like where are they made? What would the answer to that be? Liver. Are they specific? No, they're inflammation. Good. The second line of defense is non-specific. What's the opsonizer? God, I gotta quit saying that. That's awful. Awful. I'll work on that impression for next semester. C3b, and then the MAC complex, everybody go with C5 through 9. Also know those 4 things that complement proteins do. What is inflammation? It's redness, heat, swelling, pain, and loss of function. A lot of textbooks like to take you through the Latin terms for that, like dolor, rubor, tumor, and I just don't really see any need for that. Inflammation can be caused by just about anything. An infection, an injury, tumor, anything can cause inflammation. If it pisses off your second line of defense, if it's not supposed to be there and your second line of defense is trying to clean it up, it's going to become inflamed. Arthritis is another one, autoimmune disease, a common cause of inflammation. So inflammation, a very general term that a lot of people mistakenly interchange with infection. Infection is only one type of inflammation. And when you have inflammation, it gets red. It gets, think of something really almost minuscule, like a mosquito bite. If you get a mosquito bite bump and it's all itchy, is that inflammation? Yeah, it's inflamed. Your body is inflamed where the mosquito bit you. Does it turn a little red? Yeah, does it get a teensy bit warmer? You may not have checked the temperature, but it does get a little warmer, and that's because the blood vessels are more dilated there. Does it become a little bump so you can feel it? Okay, and that, I know that a mosquito bite isn't the best example, but loss of function, the skin overlying that mosquito bite, is it in its maximal state of usefulness? No, maybe the melanocytes are a little squished, so they're not making pigment, okay? It'll go away, it'll heal. But what if you do have rheumatoid arthritis, and that inflammation is affecting all of the joints of your hand, your left hip, and your right knee? Is that swelling going to be a little bit different experience? Is it going to be warm? Is it going to be red? And now, is my joint not going to work as well? I can't use my hand. That's what we mean by loss of function. Obviously, there's levels of inflammation, mosquito bite to rheumatoid arthritis to your body's response to metastatic cancer. Okay, but inflammation is a very general term. What I want you to know is the steps. These steps, that's the middle of this section. I want you to know in order these steps. General, this is very general, steps of an inflammatory process. First, there is vasodilation. In fact, the minute you get bitten by a mosquito, that part of your body has little sensors and damaged tissues which immediately result in vasodilation. Increased blood to the area. Divert traffic to the area. Increased vascular permeability. That means the blood vessels get a little leakier around that area. So not only are they dilated, they're leakier, so, stuff can get out, like complement proteins and plasma, and eventually even white cells if they need to get out of the blood and into the tissue. finally, white cell adherence, and I kind of jumped onto that during that last one. But as the capillaries get more permeable, white cells, remember, white cells can't control their moving. They don't have flagella. They just happen to be in blood, which is being pumped. So they go, I can't stop. It's like you're in a river and you can't get to the sides. Well, you can't stop flowing down that river if you don't. But as inflammatory proteins start to appear, the walls get a little stickier, and the white cell gets itself pushed on the wall, and it kind of starts tumbling down the wall of the blood vessel, slows down, and gets out. White cell adherence. It's a very complicated. If any of you have ever heard of diapedesis, that's what that is describing. It's a white cell that is basically trying to get itself slowed down so it can slip out of the blood vessel. Again, know those 3 steps as they're written in the handout. You're good to go for a question on the steps of inflammation. Be careful if we do steps of coagulation later, they sound a little bit similar.
So you don't need us to know the purposes or signs?
You do not. I'd love for you all to read through that, think about it a little bit, but I'm not going to worry too much about those because I think you already probably know at least the signs and symptoms. Might not be a bad idea to hash out a couple of abbreviations for you. They are in that section. APR is acute phase reactants. Whew. Sorry, stinky pen. So why do I keep smelling it, right? ESR is erythrocyte sedimentation, I'll write it out, sedimentation rate, or SED rate is what a lot of people call that, SED rate. I'm going to explain these in a minute. Again, I know they're under a section I told you not to worry too much about, but I want you to know what these 2 terms mean. They're going to appear later on in this handout. Acute phase reactants are immune proteins, like complement proteins released by the liver and some antibodies and cytokines released by your lymphocytes. Acute phase reactants. If you just think of them as complement proteins, you'll kind of get the gist here. Okay? What happens to my blood if I crowd them up with complement proteins? Does it get more or less concentrated? More. Okay. What effect might that have on the fluid in the nearby tissues? Pull it in, draws in more water. Okay, so these are all things that we want to consider as somebody who has a lot of inflammation. Erythrocyte sedimentation rate is this. If I drew your blood and put it in a tube and then just set it down, not spun it down, just set it down. Oh, and I also have to put a little anticoagulant in there so it doesn't, harden or clot. But I put some anticoagulant in there to keep it liquid, and I just set the tube down. What I'm waiting for is your red cells or erythrocytes to settle or sediment to the bottom. Because they're the densest cells in your blood, they're going to go to the bottom of the tube. And the sedimentation rate measures how long it takes your red cells to settle into a tube. Would you think it takes longer or less time for the red cells to settle if I had a lot of proteins in the plasma? Longer or shorter? Okay, does anybody vote for longer? I vote for longer. It's longer. If you have a lot of protein in liquid, it's harder for the other big stuff to get around it and settle to the bottom. So in people who have inflammation, we are going to see an increase in acute phase reactants, things like complement proteins, and we're going to see an increased SED rate, or erythrocyte sedimentation rate, because of all these proteins. The red cells take longer to sediment. Okay? These are really commonly done, actually this one especially is commonly done in diseases like rheumatoid arthritis, sometimes just to monitor therapy. Like if they're going to put you on a new treatment, they check your SED rate before the treatment, and then a month or two later they come and see if your SED rate has improved at all on that medication. They of course want to know about your symptoms and your experience too. Okay? SED rate and APR. Now we're all the way to third line. The third line of your immune system. The third and final. There's no fourth line. It's the third line. There are two branches of this, and the second branch is kind of also split into two branches. The two branches are humoral immunity, and from here forward, you should associate humoral immunity with B cells and antibodies. B cells and antibodies. Okay, we talked about chickenpox in this class before. I'm one of the ones who got chickenpox, therefore I'm naturally immune to it. I got it when I was a kid. Do you think I would have been exposed to it since? Probably. But when I was a kid, the first time I got it, my immune system really wasn't practiced at fighting it. They're all like, oh my God, we've never seen this virus before. What do we do? What do we do? They're all talking about it, and at that point I'm getting a rash and a fever and held out of school for a couple of days. Then my immune system figured it out and said, oh, we know how to kill this virus, let's go. But then when I got exposed to chickenpox again, my immune system didn't waste any time. It had already figured out how to kill it, so it took it about 3 seconds to turn on these viruses and say, I don't think so. You're not going to fool us twice. And that's really what your third line of immunity is. It not only is specific for a particular antigen, it gets better at killing that antigen at every opportunity it gets to kill it. And in fact, what vaccinations are scrimmage games for certain important antigens. We don't want you to get hepatitis B by working at a hospital. So when you get a job at a hospital, they give you this schedule. And they tell you on your orientation day, you take first, and a month after that, you take second, and 6 months after that?
6 months after the first one.
After the first one, okay. So it's a set of 3 vaccinations, and all that's doing, it's a fake hepatitis B virus that has the right antigen but can infect you, to tell your lymphocytes, hey, we want you all to get really good at killing this in case you see it come by for real. And that's what vaccinations and immunizations are. They're giving your third line of defense a scrimmage game, so the real game comes, they're not going to waste any time doing their best to kill it. And B cells and antibodies are a big part of that. Okay? When I first got chickenpox, it took my body a lot longer to make antibodies than the second, third, fourth, fifth, etc. times that virus got in me. Okay? And that's why I didn't get sick those other times, because my immune system said, I don't think so. Flicked it right on out. Okay? So the other one is cell-mediated immunity. That's the other branch of your third line of defense. This is T cells. You hopefully all met B lymphocytes or B cells and T lymphocytes or T cells in your A and P. They're all born in the bone marrow. B cells mature in the bone marrow, and B cells are the only cells in your body that make antibodies. If I ever ask you where an antibody is made, the answer is a B cell. Okay? T cells or T lymphocytes, also born in the bone marrow, but they go to the thymus for their training. That's this big gigantous organ we all had in the top of our chest when we were younger. But assuming your immune system was healthy, once all the T cells were trained, no thymus anymore. It goes away. Okay? Adults don't really have it. There's just a little stitch of tissue that is there in case you need your thymus again. And we don't really need to go into why that might happen. T cells are broken into 2 groups. Cytotoxic T cells, also known as CD8. You all may not be familiar with this CD, which stands for cluster of differentiation. This is a group of self-antigens, antigens that your immune system is supposed to be fine being in you. And your T cells and B cells carry some of these antigens. CD8 T cells are also known as cytotoxic T cells. They kill stuff. They kill stuff by poking holes in it, literally. Whether it's a bacterial cell or a cancer cell. They kill by poking holes. CD4 T cells are also known as helper T cells. Helper T cells. They don't kill, they direct killing, kind of. Like, I hire people to kill for me, kind of thing, you know. I think they talk like that in the mob, but I've never really worked for the mob. My application was turned down. I don't really think they have an application process. It's kind of a word of mouth thing. Sorry, I'm just entertaining myself, apparently. Don't worry about TH1 and TH2 yet. We'll have a big diagram to explain those. Those are varieties of helper T cells, but we'll talk about that in a minute. B cells, antibody production. Don't worry about MHC yet. We're going to talk about it. And when a B cell gets really, really good at making antibodies, we call it a mature B cell or a plasma cell. Plasma cell. So if I ever mention a plasma cell, that's just a really experienced B cell. It's really good at making antibodies. And we will get to figure 713 here in a minute. Let's go to page 2.
What's a mature B cell or a T cell for plasma?
B, mature B cell is what a plasma cell is. Page 2 begins with major histocompatibility complex, parentheses MHC, close parentheses, molecules. These are proteins that cells use, your cells use, to present antigen. Okay, so if I have, say, a stomach cell, let's say I ate something that's infected. I don't know, it's infected by bacteria or something. And one of those bacteria gets into my stomach cell somehow. My stomach cells actually have the ability, they've got some enzymes in them, plus that thing that got into a stomach cell is probably pretty spent from the acid journey it just took, so it's weak. So the stomach cells probably like, literally, get in my belly. You get in my belly. And it breaks it up. And now I can take pieces of that bacteria and show it to any immune cells. And it has to put those pieces onto an MHC molecule for your immune cells to look at. The whole point being, hey, this is something I just ate. Do you need to mount an attack against it? That's what MHC molecules are for. If you develop cancer, say in your liver, the first cell that got cancerous probably tried to warn your immune system by taking pieces of itself, putting it on MHC molecules and saying, these are kind of funky looking antigens. Anybody got a problem with that? And that's why they say that when you get cancer, your immune system knows it first and starts fighting it. It's just that a lot of cancers overwhelm your immune system. So antigen presentation is a really complicated thing. Just remember that your cells, when they present antigens, they have to do it on these major histocompatibility complex proteins. We will only meet 2 of them. There's actually 3 classes of them. There is MHC1 proteins. MHC1, all nucleated cells have these. All nucleated cells. That's pretty much every cell except what? Red blood cells. Good. Your red blood cells don't have nuclei, so they don't have these. But skin cells, brain cells, immune cells, heart muscle cells, bone cells, they all have, if they have a nucleus, they have these. MHC2 molecules are only found on macrophages and B cells. Only on macrophages and B cells.
For macrophages, is it always a lowercase n or does it matter? For like the.
No, I always use an uppercase, but it doesn't have to be capitalized. Okay? So what kind of MHC molecules does a macrophage have? 1 and 2. Everybody clear on that? Macrophages have a nucleus. Every nucleated cell has an MHC1. Do B cells have a nucleus? Yep, so they also have MHC1. But they're the special ones who get an extra kind of MHC protein. Okay? When we give organs, when we transplant a living tissue from one person to another, you all are aware that we test compatibility. Compatibility is these. This is what we're testing. These are coded for by HLA genes. You do not need to know what that means. Human leukocyte antigen genes. And those are the panels we run. If you want to put my kidney in somebody, they want to compare our HLA genes. And if they're really close, that means our immune systems are really close. Okay, but MHC1 only or on all nucleated cells, MHC2 only on B cells and macrophages. And these are only recognized by CD8 T cells. MHC1 presentation proteins, when an antigen is on there, the only cell that can react with it is a CD8 or cytotoxic T cell, a killer. And since lymphocytes are specific, if that happens to be the antigen that that cell is specific for, it will kill whatever is holding that antigen. But these are only recognized by CD4 T cells or helper T cells. And I think we did the 2418 the other night. 2418, who do we appreciate? T cells, okay. That's not like for fun. It actually reminds you 2418, who do we appreciate? T cells. A reminder that if I give you an antigen on an MHC2 molecule and ask you what cell is going to react with this, the only possible answer is a CD4 T cell or a helper T cell. But if I put an antigen on an MHC1 molecule, it will only be a cytotoxic or CD8 T cell that reacts with it. Okay? Questions to this point? Antibodies. Antibodies. Remember, the term antigen is a little identification marker for a cell or any piece of organic tissue. Antigen, a marker. Antibodies specifically are proteins made by your B cells to help your immune system kill stuff. Their general structure is the shape of a Y. And what they do is, this is their specific binding region for antigen. We call it the variable region. But this is the constant region. All antibodies of this family are the same here, but they're different here because they are specific for different antigens. They're also known as immunoglobulins, abbreviation IG. Immunoglobulins. Immunoglobulins. Okay? You should know the 5 things antibodies do. Namely, they neutralize. I'll explain a couple of these when we get through the list. Neutralize. They also opsonize. They agglutinate. They precipitate. Almost sounds like a poem. Some of these words rhyme. I should have said it like a poem. Again. And finally, they activate complement. Activate complement. So that's not necessarily obvious stuff. One thing you didn't see there is kill. Antibodies do not do any killing directly. They help other cells kill. So for neutralize, if it's a motile bacteria Antibodies help slow it down, neutralize it, so it can't run away. Opsonize, we've already defined that, promotes phagocytosis. So if you cover a little bacteria with antibodies, it'll make it look really tasty to a neutrophil. Like putting chocolate chips in pancakes, although you don't really need to add chocolate chips to get me to eat pancakes, but some people think they're better that way. Oh, it's for dessert tonight. Anyway, rolling along to agglutinate. This means it makes stuff sticky. If you cover cells with antibodies, those cells get sticky. Now they stick to each other. And everybody in here who did the ABO blood testing in your A&P or biology classes saw this with your own eye. What we do with that is we put antibodies on your red cells, try to figure out what antigens are on them. A, B, both, or neither. That's for our blood types. The antibodies make them stick together so much that I can actually see the agglutination, the clumping, if you will, with my naked eye. So they make stuff sticky so it clumps up. That's what agglutinate means. Precipitate. If something is dissolved, if there's an antigen dissolved in your plasma, antibodies will make it precipitate out. And finally, activating complement is just turning on the complement proteins. Don't worry, I'm not going to ask you all to write an essay about what those words mean. I simply want you to recognize those words as all being functions of antibodies. There's a little confusion here possibly when I say activate complement. What line of defense is complement? Second, or inflammation. And what line of defense is antibodies? Third. They're two different lines of defense. Okay, well, if the United States was invaded, well, I mean, by aliens, would it just be the Navy responding? Or if it was a real threat, would it probably be Army, Navy, Air Force, Marines, and every able-bodied American with a shotgun, which is, of course, tons, right? You know, I just say, oh, just let the Navy handle it. Okay, what if the Navy can't handle it? What do you need the Air Force involved? So if we have a conflict, we usually want all branches of our military at least available, and then as we start to take on that enemy, I'll stop with all the war games, don't worry. I come from a military family, but I never served. All the war games, you figure out what works best, and you might eventually, against certain enemies, say, hey, you know what, the Air Force is all we really need to take out these targets, so you can back off on all the others. Your immune system works the same way. Just because we advance to the third line of immunity doesn't mean the neutrophils and the macrophages say, all right, it's okay, no you need the special forces, I guess they're special, they can go. Everybody stays involved until there's literally a reason for them not to be. So there is going to be some overlap between second and third line of immunity, like antibodies activating complement. Here's one reason it makes sense. Did complement proteins opsonize? And do antibodies opsonize? So if you're an antibody, would it not seem like complement proteins kind of help you with one of your jobs? So why not activate them and get a little bit of help with a lot of opsonization so all this bad stuff can get the faces chewed off? There are 5 classes of immunoglobulin. The 2 most important ones on this list for you all to know are IgG, immunoglobulin G, is what that stands for, immunoglobulin G. This is the most abundant antibody in an adult. It crosses the placenta to help protect baby. And it is your main memory immunoglobulin. The first time I fought chickenpox, I didn't use immunoglobulin G. But the next time chickenpox tried to get in me, I remembered, my immune system remembered, and used IgG. That's what it means by being the memory antibody. It's the one used for the second and all subsequent attacks. IgM is a 5-part or pentamer antibody. Here's all that means. I'll use the word pentamer in the exam, but here's what that means. It's like 5 Ys. It's got 5 pieces to it. Okay, that's what IgM looking like a pentamer means. And this is your initial exposure antibody. When I first got chickenpox, my body was relying on IgM to fight it. And it's a slower working antibody. That's why I got a little bit sick for a couple of days. But then the second attack on my body, it was all up to IgG, which took care of it quicker than I even knew I had it. Finally, there is, I know I said 2, but I want you to know a little bit about IgA, because it'll come up later. IgA is a dimer. That means this. It's 2, not 10. It's not a dime bag. It's a dimer. Anyway, so sorry about that. Dimer 2. Secretory antibody. This stuff is made and then it's oozed out in your mucus of your airway and your digestive tract. In case any troublemakers try to come in through that portal of entry, there's already a little bit of IgA antibody there coating them and making them look really tasty to a phagocyte. IgA, your secretory antibody. Okay, it's a little section, but know that stuff on antibodies. I'll probably, again, ask you 3 or 4 questions about antibodies. And again, some of you will be seeing results that involve antibodies. Like I think I mentioned in our micro night together, that oftentimes it's easier to diagnose infection by testing people for antibodies than for the actual virus that's infecting them. Because their immune system is fighting the virus and making tons of antibodies, so all I gotta do is look in their serum and see if they've got it. I shouldn't have anti-Hep B antibodies in my serum if I'm not infected by hepatitis B. Yeah.
Back to the predominant of the IgG, the memory, how does that play into the fact with chronic infections? So like if you get the same illness over and over?
You don't win every battle. I hopefully have won every battle with chickenpox that I've confronted, but I'm choosing a real easy foe there to paint this picture. If I have rheumatoid arthritis, okay, what that is, we'll talk in a little more detail about it, but what an autoimmune disease is your immune system is attacking a self-antigen, something that's supposed to be there. Will they ever get rid of it? Not until all your joints are chewed away. And you know what, a lot of people with rheumatoid arthritis, they feel like that's exactly what's happening in their life. But the problem there is they never win the battle. And your body in an autoimmune disease will do the same thing. Get the IgG involved. They remember how to kill this. Well, the IgG is like, oh, I'm chewing away at these antigens trying to kill it, but they keep coming back. So there's one example of where a chronic infection. The other one is if it's a chronic infection. I meant to say before chronic inflammation, but if it's a chronic infection, maybe it's just a bug that your body isn't able to defeat. Hepatitis becoming a chronic disease would be an example of that. It's a really good question. I don't mean to simplify it like everything is a win or a loss and a quick game. Some of the games last years. Okay? Antigen. We've already defined it. It's a little marker, and I want you to just think of it as something that defines tissue as self or non-self, and that your body is basically supposed to get rid of all non-self antigens. That's what your immune system is about. Do not worry about antigenicity. I'm giving you too many lists, so let's cross one off. I won't ask you to describe antigenicity or those characteristics. What that basically means is the more foreign it is, the bigger it is, the highly complex chemically it is, and the more of them there are, makes it a more effective antigen, meaning more likely to elicit a response from you. I will not hold you responsible for that information on the exam. ABO compatibility. Did we do a little bit of ABO in the first unit? Did we not get around to ABO in the first unit? I knew that. You are like, no, but if we said yes, could we skip it? No. Let's not do ABO tonight. Let's everybody maybe review ABO and maybe the game of how to play it. And we'll do it in class on, when's our next meeting? Tuesday? Okay, by now, by now, a lot of you have had this 2 or 3 times, biology, A&P, microbiology. It's got to be something that's clicking. You've got to let this click. Even if you're sitting there like, uh-oh, you don't really remember this. But you could go home and review notes you've taken and say, oh, okay, I remember this. It may not be fun. I'm not saying it's fun. But I want you all to understand the basics of blood typing. In effect, let's take somebody just with type A blood here. I tell you, this person, I put their blood in this tube, they have type A blood. So what 2 things can you tell me about it? What 2 things do you know are in that tube if they're type A blood? An A antigen, is that what a lot of you were saying? An A antigen on the red cells. That's how we define blood type. What else do you now know is in this tube? An anti-B antibody. That means in the plasma, there is a protein weapon, an antibody, that will kill anything that has the B antigen. Does my red cell here have to worry about that? No, it doesn't have a B antigen. I only have to worry about it when? If I decide to do what to this patient? Transfuse type B red cells in them. That's also a malpractice suit, a negligence suit, a big court case, and the patient's going to win a bunch of money and they don't even need a lawyer to do it because you put type B blood in them, for crying out loud. You don't do that. Okay, so I want you all to get that game, and it's certainly under ABO. You should have all at least learned that, and maybe I'll add a little bit of the RH to it when we get together Tuesday and talk about it. Ashley?
This is probably a dumb question, but what happens if you do put the wrong blood in somebody? What happens?
That's most certainly not a dumb question. It's a great question, because we tell you how awful that is to do. We never do it. You're allowed to say, well, why? Why? What? It's not so obvious, is it? What did I tell you the things that antibodies do? They opsonize, they agglutinate, they precipitate, all that stuff. Okay, if I put a bunch of red cells in this patient's blood that have a B antigen, these antibodies are going to find it and be specific for it. And they're going to make all the red cells sticky. And now the red cells are going to clump together. And they're going to get jammed up in my tiny little blood vessels. And that's going to piss off my immune system. And then my immune system will say, what the heck's that doing in there? And make a bunch more of these antibodies to go out and find anything with the B antigen. And if you transfused 1 trillion red cells with B antigens on it, that's going to be a mess in me. And if no intervention is made, all the clogging up of my blood vessels and the widespread inflammation I have will kill me.
Well, how do you fix that? Can you?
It's not really reversible after a certain point. That's why, how many times have you all been to the doctor lately and there's scan, get just a number. Sorry, you are. You scan. Hi, I don't want your name, I just want to scan your bracelet. Yeah.
Is this patient going on dialysis?
Yes, in a case, most patients, first of all, what is my body going to do to a bunch of red cells covered with antibodies? What's my spleen going to do to those? Kill them. They're not normal. They're like, freak, you're dead. It's taking you out. And what's going to come out?
Hemoglobin.
And thus, bilirubin. Yeah, my liver can only handle a certain amount of bilirubin, the regular expected daily amount. If I put a couple of units of these in, that's like 10 times as much bilirubin as my liver is designed to handle. So patients who get this mismatched transfusion oftentimes will start to turn jaundice within minutes after the transfusion. They might feel short of breath, they might feel a rash, they might feel pain. Any symptom during a blood transfusion, you monitor and you discontinue the transfusion immediately if you think there might be a problem. If, of course, you did transfuse 2 units of type B blood, the first thing you do is you try to dialyze all the bilirubin and the other split products off of them. And there's a chance, but if you didn't catch it in time, 2 units of blood, that will kill someone. Yeah, it's a really, really unmistakable. That's about giving a type A person type B red cells is about as big a mistake as amputating the wrong leg. It literally is just, there are so many checks and balances through blood banking now because of it. It's just inexcusable. Yeah?
I apologize for backtracking a bit, but I know in some cases they'll give immunoglobulin as preventative for some diseases.
Okay, so, and I don't want to get too into that yet. We'll talk about that when we do ABO, but the truth of red cells is it's not just ABO and RH. You have about 30 other antigens on your red cells. the ones that we have to match up are your ABO and RH. So when you come in and I know you're type A negative blood, then I'm going to try to transfuse you A negative blood. In fact, I'm going to transfuse you A negative blood if I'm in a big hospital because I'll have it. But then you might get a little bit jaundiced after an hour of that. And I'm like, but A negative patient, A negative blood products. What's happening is your body is reacting to some of these other antigens like Kel and Duffy and P and I. They got weird names. And if I know you have to have A negative blood and all I have is the blood that you're going to have a little mild reaction to, won't kill you, but you're going to react to, I can maybe give you immunoglobulins to turn off the antibodies in you that will do that. Really complicated game, but again, any of you that are thinking about medical lab science, I'm a big promoter of medical lab science. Blood bank is one of the 4 branches of medical lab science, and I just loved learning from them down there in my time training and working as a pathologist. MLS is a great field that a lot of people don't know about. So give it some thought if you're not sure you want to do patient care. Yeah?
Is that why they give immunoglobulins for like prophylaxis treatment after you get a transplant?
Yes. For kind of the same conceptual reason. Obviously different antigens involved. But what they're doing there is giving you antibodies against your own antibodies, so your own antibodies don't hurt the kidney we just put in you. We only do that for a temporary amount of time, because now what does that do to your immune system? We're suppressing your immune system, and are those patients more prone to infections?
Yes.
Absolutely. In fact, that's one of our biggest fears in a transplant patient is we're going to suppress their immune system. I hope that doesn't give them an infection. Yeah.
Is that kind of like what they do to RA patients as well? Because my stepdad has RA and they,
Rheumatoid arthritis?
yeah, to suppress his immune system.
Maybe. I'm a little not quite as adept in my treatments for stuff like that, but it makes perfect sense. And there are about 20 new therapies for RA, and everybody's just crossing their fingers that one of them turns out to be the magic solution. Quick one?
My aunt got diagnosed with RA like a couple years ago, and she said they have her on like a really low dose like chemo medication.
Yeah, methotrexate is usually what they start with, which is a low dose chemo. And it's really good at suppressing your immune system. What does cancer do that we want to stop? In one word, it begins with a G, grows. So chemotherapy agents are designed to kill growing cells. Now, in the early days, what did that mean for the chemotherapy patient? Even if I killed their cancer, what are they losing? Hair, okay, what else? What am I really worried about inside their bones? Bone marrow, that's growing blood cells. So, but what they learn because of those side effects are, these chemotherapy medications affect white cells. Some people don't have cancer, but their immune system is their illness. So maybe we could lower the dose and just have it affect the white cells. So that's where the chemotherapy agents are useful in a really powerful autoimmune disease. They usually start them on non-steroidal anti-inflammatories, and once they break through that and they're not helpful, they'll try stuff like that. You all will find, any of you that go into it, you all will find, there's like 20 different, they call them disease-modifying rheumatoid drugs that they try on patients, and some patients, this one it might help and that one have no effect. So it's kind of a shotgun approach. All right, well, I wasn't going to spend any time on ADO, but let's just see where we get. I really want to get to this picture by the end of the night that I can do for everybody, and if we can get through that, we'll be good to go. I'm going to jump down to the immunity section under cytokines. We will do cytokines, but I'm going to do it with my picture. So let's go to the immunity. This is pretty straightforward. It's 4 categories of immunity. You need one of 2 words on each side. On the left, you need either active or passive. That's what my A's and P's are. And on the right, you need either natural or acquired. That's what my N's and A's are. And you combine those word pairs to make 4 different combinations, like active, natural, immunity. Active, natural. What that means is that it is a natural process and the patient in question is actively doing the immune system stuff. So an example of that would be when I got chickenpox. I got it got in me, my own immune system naturally learned how to kill it, so I am now immune to chickenpox. That's active natural immunity, and I think I even used, well, I didn't use chickenpox, but an exposure to say a virus. Active acquired immunity is what a lot of you got with respect to chickenpox. Those of you who didn't get chickenpox when you were young because you got vaccinated. We call that active because it's still your immune system doing the work, but you acquired the technology via the vaccination. Okay? You probably would have become actively natural, immunized to chickenpox. I just thrashed that sentence. But you probably would have, but now that we've developed the vaccination, we went ahead and did it for you. You acquired now the immunization that way. Passive natural. Passive means the patient in question, it's not their immune system protecting them. And the only passive natural immunity is when newborn baby is still being covered by mother, okay, from immunoglobulins that got there across the placenta, and of course IgG is also secreted in breast milk, helps protect the baby. The baby's immune system isn't doing it, so it's passive. It's somebody else's antibodies protecting baby. But that's a natural process, so we call it a passive natural immunity. The last one only existed it probably was discovered sometime during my life. They were doing it before I got to graduate school. But passive acquired is when, let's say, I just don't make antibodies to hepatitis, and I get into hepatitis B, and I get infected by hepatitis B. Uh-oh. I got infected by hepatitis B, and I don't make antibodies for it. Well, luckily, in the world of technology, what I can do as your physician is go vaccinate some willing patient with hepatitis B vaccine, someone with a healthy immune system. Their immune system, as a result of that vaccination, will start to make anti-hepatitis B antibodies. I can suck those antibodies out of their plasma and put them in you.
How do you get those exact antibodies?
And questions for your MLS teachers when you get there. We have literally, you all may know this already, if I want to draw somebody's blood, if you go to the Red Cross to donate blood, you all should, first of all, good for you all, but they can actually, in a hospital, if the circumstances warranted, they could hook me up for a blood draw and put a filter on it so that the only thing they're getting out of me is white cells. So that technology has advanced so far that now what they can do is draw your plasma and then put it in a special machine, and then out this tube comes some of your coagulation proteins, and out of here comes some of your antibodies, and out of here comes some of your hormones and albumin and other things. So by the time they get done sucking stuff out of your plasma donation, you may be giving blood products to 20 different people. It's amazing what they can do. And they literally will do what I described. They will vaccinate somebody, they'll have a subject patient who's healthy, vaccinate them, draw their blood the next day, isolate the antibodies, mass produce them, and give them to a patient who needs them. That's what passive active immunity is. It's really, really complicated technology. That's a great question, how. That's about as good an answer as I can give you. All right, everybody got those down? Okay, well, I think it's probably time to do the picture. Okay, and the picture, I keep calling it the picture. Everybody's like, there you go, what are you talking about? Did I miss anything? There's no picture in your handout. It is this figure 713 notes that I'm still hoping, again, does anybody have the 6th edition text with them? 6th edition? Really? Is it the 6th edition? Meyer, real quick? Just want to check something. We didn't have this. We didn't have this the other night, did we? Those of you who were here.
No.
We didn't have this. Okay, so let me just.
special.
Oh.
Yeah, they took it out just for you, Jan. They did, they took out the Just for this.
I just don't want you all referring to a ghost diagram and let's see, 712. Yes, it is figure 713 in the new 6th edition book. For those of you that have the old book, it's a picture. It's this picture here that on the right has a stack of 4 cells. None of the other diagrams has that. But, well, in the 6th edition, it's 170, and it's figure 7-13. I can't remember what the figure number was in the old book. It's close, but it's empty. So that's, but I'm going to do it for you all, so you're not going to need the book. I just wanted to make sure we were making the right reference. So the last definition we need before we start this story is cytokine. Cytokine. And I want you to think of these, well, I'll just tell you what they are. They're called immune modulators. Immune modulators. They're like little pieces of protein and sugar that help white cells communicate with each other. White cells are your immune cells, so immune modulators. They help the communication between white cells. Okay, and this is the story of a macrophage, which we're just going to call an antigen-presenting cell. Remember, any nucleated cell can present antigen in your body. Most of them have to do it on an MHC1 molecule. But a macrophage has both. So let's say a macrophage just ate a bunch of stuff, and it wants to randomly show this stuff off. Some of the stuff it puts on, and I'm drawing this as a square-shaped receptor, some of it puts on an MHC1 molecule. Who's going to respond to that? CD8 T cell. A CD8 T cell is the only one that will recognize antigen in that kind of protein. Okay, and there's nothing real excited about that. If the CD8 T cell recognizes that as trouble, it will kill the macrophage, it will have a bunch of babies, and those babies will go out looking for the same antigen and kill any cell that has it. Don't worry, we'll make more macrophages. The macrophage is cool with that, believe it or not. It's a suicide mission, kind of. But macrophages are endowed also with an MHC2 molecule. Good. And I'm going to make that one triangular. I guess I could be using colored markers, but I make a mess of my hands when I do that. So this is an MHC2 molecule. Who's going to recognize antigen on that? CD4 T cell. And a CD4 T cell that has never played a game before, it's its first action. Like, oh my god, am I ready? Do you think I'm ready? I'm going to kill that. I'm going to kill it. Actually, is a T helper cell going to kill it? No. Helper cells don't kill. But this rookie, if you will, its first time in battle, is called a generic T helper cell. A generic T helper cell. I put TH with no other numbers or letters there. That tells you it's generic. It's yellow is yellow is for somebody who's kind of a coward. What's the first? Green. Green. Is that what a rookie is? Green.
Yes.
Are we allowed to be talking about this? Did I do something wrong? Sorry. That thing is green. I've never done this before. Very generic T helper cell. So the macrophage is going to help it out. As long as this T helper cell comes up and says, yes, that's the antigen I'm specific for, the macrophage helps it out by squirting it with this stuff called interleukin 1. Interleukin 1. IL-1. I wrote it here because it is one of the cytokines we're going to talk about. And all that does is activates this generic T helper cell. It's like a little pep talk. Come on, you can do it. Activates it. Gives it confidence. And that moment that it's been activated, this cell is now officially a T helper precursor cell. Just because it got activated. It recognized its antigen, the macrophage showered it with interleukin-1 to activate it, and at that moment, it graduated to become a T helper precursor cell. The T helper precursor cell does something a little weird. It showers itself with IL-2, that is interleukin-2. And what that does is it makes this cell do mitosis many times so that you have a bunch of identical THP cells that are also going to go out and look for their own antigen to respond against. This step is activation. The macrophage helps activate that generic T helper cell. This step is called proliferation. If you want to fight a battle, is it better to have a lot of soldiers or one? I'll take a lot, thank you very much. And that's what this step is. It's turning this from one soldier into many soldiers that all have the same specificity.
So is the step the interleukin? So the first interleukin is the first step?
That's the activating.
Okay.
This is the proliferating.
Okay.
Good? As this one is stimulating itself to proliferate, it's thinking. And it's listening. And it's wondering, I wonder if any other white cells have seen this antigen and what they think I should do about it. I don't know. I wonder what the best way to kill it is. I have to erase my cytokine because I need the room on the board. So as it's doing that, as it is proliferating, and again, I did this the other night, I followed you all along. I've done this story in prose. I've just written this story out. So where I've introduced it, and then under presentation is where I say, this is where the CD4 cell recognizes it and gets activated. And then we go into activation and proliferation. And I mentioned all these cytokines. So this story is written out for you. I am now on the last section, the response, where this T helper precursor, or THP cell, is proliferating itself, but while it's doing that, it needs to decide which branch of the immune system is best designed to kill that antigen. It's basically going to triage the work to the best suited branch of your immune military, if you will. And here's how it does so. I think I compared this to the Who Wants to Be a Millionaire the other night. I think I thrashed that. But if you all remember that show, it was like you ask somebody questions, they get a little bit harder as the money gets higher and they're trying to win $1 million by answering all the questions. If you get stuck, you have a couple of little potential outs, like phone a friend, and the one I was referring to the other night is you can ask the audience. And that was one of the features to that show is you want to ask the audience, and then the audience would all give their answer, and you would maybe go with them. If like a high proportion of them wanted one answer, you might go with them. That's what this cell is doing. It's listening to the audience. The audience being all of the other white cells that are responding to whatever this macrophage ate. Maybe there's a lot of them responding. Maybe there's no other white cells responding. But this is going to listen to its colleagues, if you will, by recognizing cytokines and use its colleagues' input to decide how best to kill this. If it notices, as it's listening, what do all the others think? If it notices an abundance of IL-12, interleukin 12, if it notices a bunch of that, then this T helper precursor cell becomes a T helper 1 cell, TH1 cell, and turns on cell-mediated immunity, which is basically CD8 T cells. Because it thinks, based on this, it thinks the CD8 T cells will be the best ones to kill this. Okay, that's what that pathway means. But it has other options. If it notices a preponderance of IL-4, is that the one I did next? Then this TH precursor cell, instead of becoming a T helper 1 cell, becomes a T helper 2 cell. And a T helper 2 cell will turn on humoral immunity. What cells is that? B cells, and they make a bunch of what? Antibodies. That's basically, if it goes down this path, it's saying, you all are better equipped to kill this. It's a decision-making process, yeah.
Okay, so when it does all this, does that turn in the cells of the mitosis cells? Does those turn into those as well?
All of these are listening like this one
So
is.
does it not happen until after it listens?
No, it's mitosis starts way before it listens, but isn't done while this starts listening. And all these are listening. And if this one becomes a TH1 cell, all these will become TH1 cells, and now they'll all start turning on CD8 cells saying, go find that antigen.
Okay.
Good? If, on the other hand, it notices predominantly IL-6 as it listens to input from other white cells, this cell's decision is to become a TH17 cell. They really jumped about 15. I don't know why they skipped 3 through 16. But TH17 cell. And what this does is it turns on inflammation. It's basically saying, the phagocytes, they can handle it. We don't really need any lymphocytes involved here. There's one last possible outcome here, and that is if our THP cell is listening and all it notices is a bunch of IL-2. Who's the only one talking? Itself. So it says, maybe I'm making a mountain out of a molehill here, because I seem to be the only one that really cares. So I'm going to become a TH regulator cell and turn everything off. False alarm. So again, this is about the T helper cells. The CD8 T cells, they're quick. They recognize, they kill. They go and try to recognize again so they can kill more. They like to kill. That's what they're supposed to do. But the T helper cells are like, let's think about this. Let me proliferate myself a little bit here with some IL-2, and I'll just listen to what everybody else kind of says, and based on that, I'll decide which of these branches. By the way, these cells have the ability to turn on more than one branch. Okay? But what I want to ask you is questions like this. First, definitely know your MHC1 and MHC2, where they're found, what cells react to them. For this, I might ask you a question like, a TH precursor cell notices an abundance of IL-6. It is about to become a blank. What's the answer? TH17 cell. Or I might have said, it is about to turn on what branch of immunity? You're going to go with inflammation on that one. Okay, so that's how I might ask questions. I know in the diagram in the book, it buries you under some other cytokines. These steps are labeled with a bunch of cytokines. Don't worry about those. They're not inaccurate. It's just more than we need to know. I just want you to know which cytokine dictates which path. Questions on that diagram at this point? Do a few coats of paint on it, Ryan.
The parts of it that you said, we need to know where, what did you say, where they're found?
Where the MHC1 and MHC2, what cells have them,
Okay.
what cells react to them, 2418, who do we appreciate, think?
Okay.
And then this, how this cell branches out based on the other cytokine. Now, I believe I told you all I had a list of cytokines that I wanted you to start learning. Where is that? Page 3?
Page
2. I believe I mentioned that, and that looks like quite a robust list, doesn't it? Kind of like one of those lists you look at, you're like, oh, I hope he doesn't ask us to memorize all that. Whale, okay, I won't ask you to memorize all of it. But let me help you all here. This is actually going to be simplified once you know this. Look at what it says about IL-1. Released by macrophages, is that on my diagram? Mm-hmm. Yep. To promote fever and activate phagocytes and lymphocytes. Am I activating a lymphocyte here? So there's not much more to IL-1. If you liked that, look at IL-2. Is that basically everything? Okay. IL-4 is released by lymphocytes and promotes humoral immunity. Is that in the diagram? Not the released by lymphocytes part, but yeah. IL-6, released by macrophages and lymphocytes, promotes APR synthesis by the liver. Remember that acute phase reactants are complement proteins. What are they associated with? Inflammation. Good, good. And I don't want you all to be confused. Cross out IL-10. It's not wrong, I just don't want you to be confused. I'll show you why in a minute. It might be confusing. How about IL-12, released by lymphocytes and promotes cell-mediated immunity? So a lot of the cytokine list, once you're good here, you know a lot about these cytokines. These ones I'm mentioning, I want you to know what's on the list, but it really isn't much more than here. I'll give you some shortcuts here also in a second. The reason I think IL-10 might be confusing, it is the down-regulating cytokine, but I don't want you to be confused by this path. So I want you to, this is the down-regulation path, but I want you to associate IL-2 with that, because this T cell realizes I'm the only one talking. Okay? You all may learn about IL-10 later on down the road. It isn't that important to this story. Interferons. Both are antiviral cytokines. They're cytokines your body releases to help your white cells fight viruses. One of them is released by macrophages, the other one by lymphocytes. And if you look at which is which, interferon alpha, interferon A, does macrophage have an A in it? What about lymphocyte? I don't think so. The other one is interferon gamma, but that gamma kind of looks like a Y. Is there a Y in lymphocyte? What about macrophage? I don't think so. Good way to remember this. So for the interferons, know they have antiviral properties and know which cell releases them. I do not need you to know tumor necrosis factor. You can cross that and IL-10 off of that list. Last thing for the night. Let's finish off this page. It's fairly quick. We've done microbiology, that big chunk at the beginning of page 3. So when we reconvene on Tuesday night, we'll do immune disorders, and then eventually we'll get to the stress response and cancer. Okay? Probably about a lecture and a half worth of stuff left. So we didn't get too derailed by the half snow day the other night, which I hope everybody got home safely. It was kind of fluffy snow to drive in. It wasn't that icy, nasty stuff. It was fluffy. It's almost fun. Hemostasis. Hemostasis. Blood stop. Parentheses. Leaving my body. Close parentheses. That's what hemostasis is. It's clotting. It's a story of plugging up a hole that may be leaking your blood out of you. Hemostasis. 3 steps. And this is the one that I said can be kind of confusing with inflammation. Know these steps in order. They are vasospasm. How does a vessel spasm? Dilate, constrict, dilate, constrict, dilate, constrict, dilate, constrict. That's how a blood vessel becomes a drama queen. Vasospasm. Platelet plug formation. When there's did you all kind of think platelets were the end all be all with clotting at some point in your life? And maybe some of you have learned now that they're not. They're just the temporary block. They're kind of the bosses of stuff, but they're the temporary block here. Like when there's a flood and they call the Corps of Engineers to help a village from drowning, the Corps of Engineers comes in, first thing they do is lay a bunch of sandbags to stop the water from flowing somewhere. Then they figure out how we're later going to rebuild the bridge so it doesn't flood next time. Those sandbags aren't staying there permanently. They're a temporary plug. That's kind of what platelets are. Temporary plug. Platelet plug formation. The big finish of clotting is called coagulation. Coagulation. And it occurs in 2 protein cascades. The term cascade means one gets activated and it activates the next. And then that one activates the next one. It's like a domino effect of activating proteins. That's what a cascade is. The 2 cascades are known as the intrinsic pathway or intrinsic cascade and the extrinsic pathway. One of them, the intrinsic, is initiated by platelets. The other is initiated by damaged tissues. If you're bleeding, is there at least one blood vessel broken? Gotta be, or you wouldn't be bleeding. So that's the damaged tissues we're talking about. They run together. In a healthy person, both of these are operating. If you cut yourself, both your intrinsic and extrinsic pathways are working. The extrinsic, turned on by damaged tissues, activates a bunch of proteins. Where are these proteins made, by the way? All of them. The liver. They're all made in the liver. All these proteins made in the liver. People who have liver disease, do they get infections more than other people? That's because their livers aren't making those complement proteins we met earlier. Do they bleed easier than other people? That's because their liver isn't making these coagulation proteins. Do they turn a little bit yellow? That's because their liver has no time to process the bilirubin because it's too busy processing whatever its problem is, usually alcohol or hepatitis virus. Okay, so all this stuff, when I say made in the liver, I know it kind of sounds redundant, but when you see somebody in liver failure, you're going to literally see a train wreck patient because they got so much stuff going on because the liver is so important. So let's see, the intrinsic cascade, that's turned on by platelets. It activates a bunch of different proteins in order. But eventually the 2 pathways meet at the first common protein, which is called factor 10. Yeah, it's not X. I wish. That would be so cool. Factor X. It's factor 10, just a Roman numeral there. And we call our coagulation proteins factors a lot of times. Now they've merged these 2 pathways, and a couple of other proteins are activated until finally you activate the big final protein, the actual clotting protein called fibrin. Fibrin. You are not done clotting until fibrin is laid down. Okay? Once you lay down the fibrin, here's what that blood vessel looks like. There's where it was damaged. and you were bleeding, but we plugged it up and we laid down some fibrin. There it is. Is that plugging the hole?
Yes.
And is that a problem, that fibrin? Yes, why? It's like a speed bump. And if you ask blood that's flowing down a tube to go around a speed bump, what's some of the blood on the other side of the speed bump going to do? Pool and collect. And when blood sits, it does what? It clots. Yeah, you can't leave that there. Outside the blood vessel, I'm just trying to draw a big nasty scab. Is that in the way of blood flow? No, that's outside. That's a scab. It's that thing that gets all mushy when you take a shower. It's like, oh my God, is that snot or my scab? You know what I'm talking about? It's just awful. I'm not worried about that. I'm worried about this. So I need, the minute this is done, a signal is put out, we're done. Fibrin's laid down. And that activates another protein called plasmin to come in here like a little piece of sandpaper and go and whittle that fibrin bump down to the wall of the blood vessel so there's no bump anymore. Fibrin is the end of clotting, but later plasmin comes out and cleans up the fibrin. And I would ask you plasmin and fibrin that exact way. If I ask you what is the final protein in hemostasis or in coagulation, the answer is fibrin. If I want you to tell me plasmin, I will ask you what protein cleans up the fibrin clot after coagulation. Pretty clear? Have any of you ever heard of TPA? Tissue plasminogen activator is what that is. These proteins that are in this are all secreted by the liver in an inactive form, usually designated by the suffix OGEN.
I'm sorry, could you back up the TPA again?
Yes. Tissue plasminogen activator. Plasminogen is your inactive plasmin. Okay? Do you ever want to bleed? Wait a second, I better not ask that. Some people, well, actually, now that you bring it up, let's not go there. We usually don't wake up in the morning and say, oh my gosh, I hope I have an accident where I bleed today. Oh my gosh, that'd be great. But if you do bleed, do you want your body to naturally kind of clot that? Okay? Well, that's what your clotting proteins are. I don't want to bleed, but I'm really glad my liver makes fibrinogen and all these inactive proteins that in case I do bleed, I need to activate them to stop bleeding. So every day my liver makes a little bit of plasminogen, inactive plasmin, that will be activated only when I need it to break up a clot. What are most strokes caused by? Clots within blood vessels. What TPA is it something you can give a patient who you think has just had a stroke, and you can give them TPA, which will activate all of their plasminogen to plasmin, and what does this break down? Clots. If you use this wrong, that patient will start bleeding out of every orifice of their body. Basically what TPA is it's the ultimate and immediate anticoagulant. You only use it when you're almost certain a clot is causing major problems.
So how you said like they bleed out every orifice. So we had a patient came in coding. They thought she had a massive PE, so they gave her TPA.
Ooh.
Later on figured out what the PE did internal bleed.
Oh.
But okay, so like it wasn't like
Let's give her some type B blood.
Yeah, so it wasn't like a bad situation because she was an employee, so we were doing all measurements. Like,
Good.
We coded her for 2 hours. So at this point, like TPA was like, let's just try it.
Okay.
And we figured out later on that she had.
So it's discontinued, probably exacerbated the internal bleed.
She's a bigger lady already. So you really couldn't tell, but her stomach was huge.
Distended.
At the end of it, yeah.
She okay now?
No, she didn't make it.
Yeah. It's an understandable mistake when you're desperate. It's like, I don't know if it's a clot or not, but if it is, it'll kill them, so I have to try it.
It was a last ditch effort, so it
Yeah.
wasn't like the first thing. We tried everything, put different lines in, all sorts of things. We got her back a couple of times, but
But she just couldn't maintain, yeah. Well, she lost a lot of blood,
Yeah.
and that's a really good experience. Well, I tell him he's having a great experience, good experience for you, patient died. It is a great learning experience, though, especially when you kind of, like, the minute I said TPA, you're probably like, oh my God, I remember that case,
And we did TPA to stroke patients.
And there's designated people there who are allowed to do it. And not every doctor, you go to your family doctor, they're not allowed to give you TPA. These are people in ERs, people in neurology clinics for an active and evolving stroke or PE. That's another good example. They want to use it sometimes. Some heart attacks are caused by blood clots, but it's almost impossible to tell, is that a blood clot or just a spazzing artery? If I give them TPA, I could cause massive problems for them if it's not a blood clot. So good experience there. Everybody got that hemostasis? This last section is really straightforward. It's about wound healing, resolution versus repair, primary versus secondary. Resolution versus repair, primary versus secondary.
Just a second.
Yeah.
We talk about the cog.
Oh, I'm sorry, and you know what, I skipped it because I will not ask you this, but you all might be interested. I put a bunch of abbreviations there. First, on the second row, under 3 steps, I put parentheses H and parentheses C. Intrinsic pathway, parentheses H, extrinsic, parentheses C. Anybody want to take a guess at what those H and C stand for? Heparin and Coumadin. That is the pathway affected by those 2 anticoagulants. So when I give somebody heparin, I'm blocking their intrinsic pathway. When I give them Coumadin, I'm blocking their extrinsic pathway. TPA undoes both. Basically reverses everything. And then the BT, PT, PTT, and platelet count and function. Again, won't be on the exam. I also won't ask you about heparin and Coumadin on the exam. But bleeding time, prothrombin, I'll write these for you. A lot of you like your abbreviations, that's why I want to write them out. Prothrombin time is PT, and then partial thromboplastin time is PTT. We measure all this stuff in somebody we think might have a coagulation problem. What that means is if I poke a hole in my finger with like one of those little glucose sticks, that should not take more than 20 to 30 seconds to stop bleeding. A lot of people it takes 10 seconds. But if it takes longer than a minute, just that teeny little pinprick, then I'm worried that their coagulation isn't working because that should have plugged up the hole by then. So in that case, we measure all this stuff, bleeding time, prothrombin time, and that tells me where in the pathway they are lacking. Do you all know what hemophilia is? What is it? Can't clot. Yeah, those are the family of clotting disorders. Do you know what severe hemophilia was about 100 years ago? A virtual death sentence. You have to walk like this. Don't touch me. Don't touch me. Nobody bump into me. Because if I just go like that, oh my God, I just hit my elbow and I'm a severe hemophiliac, I might bleed to death into my elbow joint from that. Why don't we worry about that now? We can suck these right out like antibodies we were talking about. And in fact, in a city the size of Wichita, somebody who's a hemophiliac has a doctor monitoring them, and that doctor has probably a list of 15 patients that if this hemophiliac needs the factor of choice, the one that they're missing, then they can call one of those 15 donors to come in that day, donate plasma, we'll suck out factor 8 or factor 9, whatever we need, and give it to the patient who needs it. Basically, through blood donation products, we have pretty much, it's not a cure, but we have no problem managing most hemophiliacs that way. It was not this way a while back. Kind of like how 100 years ago, what was diabetes mellitus? That was a death sentence. You know you're dying from it. And it's going to be a slow, painful, rot away in your bed sheets kind of death. And now, can we manage diabetes? I know the patients don't always do it, but we can manage it. Insulin, that's why insulin won 3 different people a Nobel Prize. Because before it was such a death sentence. Okay, thanks for pointing that out. All right, wound healing, resolution versus repair. You all can picture this pretty clearly. Are these 2 different injuries? A surgeon under a controlled sterile field in an operating room cuts me open to remove my appendix versus I jumped through a glass door and cut the skin over my appendix. Are those 2 different wounds? Yes. Well, I don't know, it depends on how much your surgeon had to drink the night before, but let's hope they're different. The surgeon is supposed to do a nice straight cut, leaving the sides in such a way that they can sew them back together, and hopefully I'll heal without much of a scar. Okay? Healing by resolution, this isn't quite a surgeon's cut. Healing by resolution is when you cut yourself in such a minor way that when it heals, you don't see a scar. Like the typical paper cut is that way. And we all know what that means. Paper cuts, they're annoying. They make you grouchy. You know right when you got it, you're like, oh man, mother of. But is that going to leave a scar? No. It's just going to burn for the day. Okay, it's not going to leave a scar. But if I accidentally put my hand into the garbage disposal for about 3 seconds while it was running, is that going to, I'm sorry. People were in healthcare. I'm sorry, I was in pathology. I didn't think that was that bad. I should have used a wood shredder? Should we have done wood shredder? No, sorry. Question back there.
Paper cut garbage disposal.
That was a big jump. Sorry, I should have warned you all. It's about to get real. Is that going to heal without a scar? That really bad injury I mentioned. That is healing by resolution. Basically, your body says, we can fix this, but it's not going to look like it did before. There's going to be some obvious scar tissue. Another example of that might be a scalpel incision, a small one on your finger. A good surgeon might be able to close it up so you have minimal scar, you almost see nothing. But if I stick my hand through a glass window and get a jagged cut, even the best hand plastic surgeon probably can't fix all those jagged cuts to where there's no scar at all.
You meant healing by repair, right, with the scar?
The first one, resolution, is healing with no scar. Repair is healing with a scar. It's fixed, but there's a scar. Finally, the primary and secondary intention is the surgeon versus the non-surgeon cut. A primary intent is usually an intentional cut with minimal tissue loss and clean edges, like what the surgeon did to take out an appendix here. By the way, I know how they take out appendixes now, but I was born a little bit before the just poke a hole and you don't have any scar. I have about a 3.5-inch scar from losing my appendix. Anybody else lose their appendix? Oh, I guess I shouldn't ask you all. Nobody? Nobody willing to say? Well, I usually have a couple of students, and they're a lot younger than me, and they tell me that it's just they've got one teeny little scar where one hole was poked, but the other hole was poked in the umbilicus, the navel, where you can't see the scar. So there really is no scar. And I've got about a 3.5-inch scar from when I was about 4 years old in the late 70s. They had to take my appendix out. My parents both had their appendixes out before I was born. Guess what their scars look like? Yeah, you could drive a bus through it. What were they doing? How many people went in there to get that appendix out? Crazy. I did stay in the hospital for 3 nights after getting my appendix out, eating Jell-O and ice cream for 3, maybe even 4 nights.
Well, it's just C-section scars now too. They're getting smaller.
They're getting smaller and smaller. And how long does an appendix patient stay in the hospital? You're out before lunch. You're out before lunch. Get there at 6, you're out at 10. In fact, they're rushing you. Go. We need the bed. We got another patient coming in. Unless you've got an infection, you're out the door. Secondary intention is not a clean surgical cut. That would be let's not go into the garbage disposal again, but again, like a glass injury. If I fall through a window and get a real jagged, messy cut, they will try to fix it, but there's just maybe not enough tissue left there to make it clean. So it's gonna be maybe a lumpy, bumpy fix. That's what secondary intent is. We're simply gonna have more extensive tissue loss when we heal. I'll be really clearly descriptive on any questions about wound healing there. Spend a little time with that lymphocyte diagram, the couple coats of paint, and that'll clear up a lot of this handout for you. Questions on anything? All right, go have a super terrific weekend, and we'll see you all Tuesday night for more awesome Unit 2 information.
And then the fingers fell on the floor. Yeah. And the fingers fell on the floor. So I well, that's when she told us that it was pretty big. Big blood. Everybody else was done. They were manager. Yeah, so then I got into and I'm like, are you getting they were fined by the city for sitting in ambulance?
What are some like the
There's 4: blood bank, microbiology, hematology, and chemistry. Chemistries are like all the little labs when you send blood in a hospital. Yeah, electrophoresis, sodium levels, things like that. The most popular tend to be the other 3. Micro is really, really popular. That's literally